Okay, well, good afternoon and welcome. I'm Mayor Jeff Lehman, and it's uh, a pleasure, first of all, to welcome you to this incredibly important discussion, which we're continuing in our community today. We have had, as I mentioned a minute ago, for those just coming in, a very strong response to this, and welcome to those who are just joining us in progress. I want to begin today's webinar with a land acknowledgement. We acknowledge that this meeting today is taking place on the traditional territory of the Anishinaabe people. The Anishinaabe include the Odawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy. We're dedicated to honoring Indigenous culture and history and committed to moving forward in the spirit of reconciliation with all First Nations, Métis, and Inuit people. A few words of introduction from me. I want to begin today by thanking those who put this event together. It takes a lot of work, and Lauren Wild from my office and her team at the health unit in support have made this happen today. And I particularly want to thank as well our 5 panelists. Dr. Rampton, Melissa, Kim, Mia, and Patrick will be properly introduced to you in a minute. But as mayor, I really want to thank the 5 of you for bringing each of your perspectives to today's discussion. This forum was originally a council direction, and city council has certainly become extremely aware in the past 2 years of the impacts of the opioid crisis. But this has taken on, if I may, new urgency through the course of COVID-19. The reality is this pandemic within a pandemic has taken many more lives. Overdose deaths are up in our community, in our province, and across our country. And so it is doubly important that we see and understand the opioid crisis as a public health crisis. This is an issue of poison drugs that are taking lives, and it is a very difficult public health issue because of the many root causes of addiction. And so it is going to require a complex solution. A complex problem with diverse root causes requires a many-faceted approach. And I was so compelled some years ago by the statement from the leaders of the Simcoe-Muskoka anti-opioid strategy when they came to City Council and said, this is in many ways a problem that will take generations to solve. But we can't wait another day in our response, and our response must continue to grow with the severity of the crisis. So I think in designing this panel today and in the very talented presenters that we have for you today, we have diverse perspectives representing the multifaceted strategy that is being pursued in Simcoe-Muskoka to respond. And I have to thank the health unit for their leadership, of course, at this moment focused on COVID-19 and vaccinations, but in continuing to carry the fight against opioids in many ways. Thank you to our incredible health unit and the people at the health unit who are leading this fight. So whether it is harm reduction, treatment, education, enforcement, all of these are critical components of our community's response to a worsening crisis. But most of all, I think I wanted to say by way of introduction today, this is a most human of crises, and it requires a human and humane response. It has been my view since the beginning that this is not something that we can arrest or should ever try and arrest or enforce our way out of, though enforcement against dealers is a critically important piece of the puzzle. This is very much a human crisis with root causes and many other very human reasons and issues. And our response as a community must be a human and humane one that respects the individuality of the reasons why people enter into addiction. And you are going to hear some of those stories and some of the responses today. And you're not here to hear from me. So I'm going to stop talking now and hand it over to Claudia. Claudia Swoboda-Guin, who is going to be our moderator today. And thank you so much, Claudia, for doing this, and to all of our panelists, and most of all to all of you watching for attending and being part of the solution and response in our city to this crisis. Claudia.
Thank you, Mayor Lehman, for providing the introductions. As Mayor Lehman has identified, this is a really important and critical issue that we really need to look at addressing. I'm going to just, I should just say my name is Claudia Swoboda-Gein. I'm a public health nurse with the Simcoe Muskoka District Health Unit, and I work in the Injury and Substance Use Program. A couple of housekeeping items that I just want to cover is that lines are muted and cameras are off, other than the panel members or speakers that will be presenting today. Just to let you know, there will be an opportunity for questions and answers more towards the end of the session. So when we get closer towards the end, or even throughout, you can certainly enter your questions in the Q&A box. A few pieces that I just want to let you know what we'll be covering over the next hour. There's so much to cover, and of course we're not going to be able to address it all in the next hour, but we'll certainly do our best to lay some groundwork to inform and educate people on what are some of the key critical issues that we really want to look at addressing collaboratively as a community moving forward. So some of our goals for the next hour are to look at overview of opioid use and harms in Barrie, the impact that the pandemic has had in further exacerbating these harms in our community, and what is being done around addressing these challenges at the community level, as well as wrapping up with not only what's currently being done, but what are some future directions, both in the short and longer term. So we do have a number of panel members with us that I will be providing a brief presentation just to give some context. And then we'll be getting into the panel member presentation section whereby we have a number of community partners. Dr. Rampton, who is emergency medicine physician with Royal Victoria Regional Health Centre and addiction medicine at the Canadian Addiction Treatment Centre, as well as Chronic Pain Centre. Detective Sergeant Patrick Brouillard, in charge of detective services for the Barrie Police. Kim Bray, team lead of the addiction services at the Canadian Mental Health Association. Melissa Hearst, who has tragically lost her son to the opioid overdose crisis. And Mia Brown, who's acting manager for the Substance Use and Injury Prevention Program at the Simcoe Muskoka District Health Unit. And just again, following our discussion, we will be opening it up to the participants. I want people just to keep in mind too, we have over 300 people that have registered, and I think this is wonderful that we have our community showing such an incredible commitment and interest in addressing the issue, becoming informed and looking at ways of how we can move forward together as a community. So in order to really address all the questions, or as many of them as we possibly can, I have a couple of people that are behind the scenes with me who will be triaging some of the questions that will be grouped into some common themes, so we can really look at maximizing our ability to respond to questions within the next hour. Okay, I'm going to just share my screen and bring up my presentation that I have here for you. So what we're addressing is opioids in our community, crisis within a pandemic. So just to bring it back, when we're speaking of opioids, what are opioids? So opioids
Claudia?
exist in both, yes?
Claudia, are you able to put it to full screen for your presentation?
Oh, is it not showing full screen? Okay, let's see. Escape, slideshow.
I believe if you click the enable editing button there that you see, you'll be able to start your presentation.
Okay, from beginning. Okay. Are you seeing
Thank
full
you.
screen?
Thank you, Claudia.
Okay, thanks, Lauren. So opioids exist in both licit and illicit forms. A variety of opioid medications such as codeine, oxycodone, and acetylmorphine are produced and used most often to treat pain. So people consume these products for medical and non-medical purposes. Opioids have the potential for problematic use because they can produce feelings of well-being or euphoria, a high. So most of the harms currently being experienced are due to fentanyl, which is a synthetic opioid that can be prescribed to patients or acquired illicitly. The presence of fentanyl and other substances dramatically increases the risk of overdose, as it's an extremely potent and deadly drug that can cause fatality, even in trace amounts. So when we're speaking about the opioid overdose crisis or poisoning crisis, what we're really addressing is looking at the fentanyl, not so much fentanyl that people are being prescribed for, cancer type of pain, that type of thing. But what we're really seeing, the problematic overdoses that are occurring within our community is primarily in relation to the fentanyl and the drugs that we're finding on the street. It is a more lethal, potent, deadly mix of drugs that are currently out there on the streets. So I just really I think it's important to really highlight that piece in particular, and that's where we're seeing most of our opioid-related deaths and harms. You don't have to go far to look in the media and read almost on a daily basis what's occurring. So we continue to see opioid-related deaths. They aren't getting better, they continue to get worse. So we know last year, Barrie had the third highest crude rate of emergency room visits for opioid overdoses amongst Ontario municipalities. How do we stop this from happening? This is happening within our community and is affecting everyone, from families, friends, community as a whole. We all are being impacted by the harms associated with opioid use. Crisis worsens in Simcoe Muskoka amid COVID-19. I don't think that's going to be news to anyone here. It just continues to worsen. I have a quote here from Dr. Lisa Simon, who is our Associate Medical Officer of Health at the Simcoe Muskoka District Health Unit. And here, I thought she addressed it beautifully. Dr. Simon is currently, extremely busy in addressing the issues in relation to the pandemic today and is unable to join us. But here's a quote from her. "The pandemic may have pushed the opioid crisis out of the spotlight, but the crisis and the burden associated with it has not gone away. In fact, COVID-19 has made a difficult situation even more challenging." So I'm just going to go and show you some stats that we have in our local area. So there's been 1,600 emergency room visits for opioid poisonings in Simcoe Muskoka. 272 of those are in Barrie alone. 600 in our region of Simcoe Muskoka, 270. So if you look at those stats, it does give you a sense of the number below indicates, so the 104 is per 100,000 population. In Barrie, 182 per 100,000 population. That's hugely significant. So since January to September of 2020, there were 94 deaths, 50% higher than the comparable average for the previous 3 years. 50% higher. These are people's lives. That is hugely significant. Barrie, of those deaths, 50% have occurred in Barrie alone. So 47 deaths were in Barrie, 50% of our region. And this is despite only having 25% of the population. So again, these statistics, they're statistics. These are people's lives, but they do help show a story. Now, we continue to get new data that comes into the health unit, and we have a team that involves epidemiologists, et cetera. So new data continues to come in. So as I share some statistics with you, new data does come in. As of just yesterday, within the past 24 hours, some further stats have arrived. So we know opioid-related deaths in Simcoe Muskoka for 2020 up to November are in fact 117. So we do have our health stats page on our Simcoe Muskoka District Health Unit website. I do have a link there, and certainly these stats get updated on a regular basis. How did we get here? So I think looking at factors that have contributed to the opioid crisis. So just even looking generally, even pre-pandemic, it is a complex, multifactorial issue, and it's no one one piece that's really going to address it. But if we look at it, and I'm breaking it down into some rather simple bullets, it is far more complex than what you see in these bullets, and far more complex than we'll be really able to touch upon in the next hour, but it will give some sense of what we're really looking at addressing. So there are psychological, social, and biological risk factors, genetics, mental health. We know there is that link between mental health and addictions, early life experiences and trauma, social determinants of health, including poverty and lack of secure housing, opioid prescribing for pain relief. Those were some of the pieces we were finding early on, particularly back in the early 2000s and a little onward. But there's also lack of access to prescription opioids leading to illicit opioid use. So when you look at that, there really is a fine balance, which we really need to look at addressing collectively. Further pieces contributing to the opioid crisis: lack of awareness or access to alternative treatments for pain, use of prescription opioids by individuals whom they are not prescribed, so family and friends, family members, etc. Illegal drugs that are laced with fentanyl and its analogs, and that's a huge one. That's a huge piece that we're currently really seeing, that we're wanting to address by way of harm reduction strategies. And there's also overall a lack of comprehensive care to respond to all the mental and physical health needs of an individual. So we can't just look at one piece of it. We can't just look at prevention or treatment, harm reduction or enforcement. I think we really need to look at things holistically. How did we get here? COVID-19's impact on the opioid crisis. So I've just covered those pieces pre the pandemic. What are some of the issues that had led us to the opioid crisis? Now try to layer in the impact that COVID-19 has presented by essentially presenting further challenges and exacerbating the problem, worsening the problem in essence. So we know social isolation in and of itself is a factor in harmful substance use, including that of opioids. With COVID-19, we know that we've had increased social isolation. So you have an increased negative impact on mental health and addictions. And we know that alcohol and cannabis use has also increased. Decreased availability of mental health and addiction services. And when I put that in, I say essentially, particularly early on in the pandemic, as people really needed to look at that face-to-face contact and how are we going to pivot and restructure service delivery models. So that became a particular challenge early on. It continues to be a challenge as we look at addressing services in our community. Using a loan increase, so resulting in less support for administration of life-saving naloxone. So in a document that was, in a document from Public Health Ontario, 3 out of 4 deaths, no one was present, so no one was available to provide the life-saving naloxone. You can't administer naloxone to yourself if you have overdosed and are unconscious. This is an interesting piece too that was recently released, I think in the past week or two, from the Canadian Centre for Substance Use and Addictions. So a new survey was released that was indicating that up to 50% of people living with an existing substance use disorder reported having increased symptoms of depression since COVID-19 pandemic started. So again, another factor that's contributing to the opioid crisis amidst the pandemic. An even more toxic drug supply on the streets. And we're going to get into some of these pieces as we get into our panel discussions. We know that there is an ever increasing toxic drug supply on the streets. It was pre-pandemic and it's just gone off the charts since the pandemic. So that is something that we are seeing in Ontario, in our region and in Barrie. So from a Public Health Ontario report, they did indicate an increase in benzodiazepine-related drugs, so primarily atizolam, which is a benzodiazepine, increase in synthetic cannabinoids, increase in fentanyl-related drugs, both active and inactive, and increase in carfentanil. So essentially, there is a really lethal, deadly, toxic drug supply on the streets. Some of this information that I've shared with you in relation to that can be found in this Public Health Ontario document. There, at the end of my PowerPoint presentation, there are a variety of links, and the PowerPoint presentation will be sent out to all participants, so you can access the links, including this report. In this report, it does indicate a number of strategies that we really want to look at in terms of mitigating the harms. In this, I'm not going to go over each piece of this, but what I really did want to share is this really does mirror, it does look at looking at addressing harm reduction strategies, increasing outreach, increasing naloxone training and distribution. But now when you look at it with this slide, I found the interesting piece, and this came from members of our harm reduction pillar from our Simcoe Muskoka opioid strategy group. And it's fascinating because what they are looking at addressing also encompasses these pieces that have been addressed in the literature reports that are in various other organizations throughout our province as well, and through that Public Health Ontario document. So it does include that expanded access piece, needle exchange partnerships, naloxone, safer use lines, which Mia will be addressing later on. So if people are using a telephone line they can phone into, advocacy pieces in relation to supervised consumption sites, drug checking, safe supply, and addressing social determinants of health. So that essentially is looking at housing, shelter, food, and access to technology. As we look at pivoting our service delivery models, technology is also an important aspect of addressing this crisis. Within our area of Simcoe Muskoka, we do have a local strategy that is looking at the various aspects of it. So looking at prevention, treatment, clinical practice, harm reduction, enforcement, and emergency management. And we're also with foundational pieces of incorporating that voice of lived experience, as well as looking at what does the research tell us as well as we move forward. You can find access our Simcoe Muskoka Opioid Strategy Action Plan on our PreventOD, so www.preventod.ca website, which will also be shared as a link in the reference section. I think when we look at this, just some closing thoughts, we really do want to look at that connection, and we really are all in this together. Thank you. Following this, I really do want to, I'm just going to stop sharing my screen here. And what I really would want to look at doing now is following up with our panel members. I think this is really the interesting part as we get into our presentation. So what I would like to begin with, and again, if people will have an opportunity to address their questions, but I will share with you the questions that are being addressed of our panel members do involve a number of questions that have come in to the City of Barrie, to the health unit. A number of people have already forwarded a number of questions that they would like to see addressed. So we've really categorized them, and we've brought on the panel members to look at addressing some of these specific questions. Once we've identified what some of these questions are and have dealt with them, we'll look at further questions that people may have today to include in these questions. I do want to begin. Now, I did highlight just a number of stats, a number of reports, all of these pieces, but I think a critical piece is really humanizing it. These are not just stats and numbers, these are human lives. So I would like to have Melissa Hearst join us. Melissa Hearst is a mother of a son who she lost, a 19-year-old son, to the opioid overdose. Melissa, are you, do you have your camera on?
Can you see me now?
Okay, I can see you now. Thank you, Melissa. So I'd like you just to open it up before all the panel members join us, is just to share with us what you feel comfortable in your own words, just your story, your story about Luke, if you can please share that with the participants.
Sure. And I thank you for the opportunity to be able to share. So my son, Luke Kitson, passed away in the early morning hours on Mother's Day, May the 14th. It was unusual for him to be home on a Saturday night. But my husband picked him up from work in Barrie, and we talked and laughed all night. And he had bought me a tulip plant because I love tulips, and my favorite popcorn. And he said, I don't have any money, Mom, but here is my Mother's Day gift. And it just meant so much to me. And as I said, we talked and laughed all through the night, and we really had a special time. And just before we went to bed, one of the last things he said to me was that he could hardly wait to be a dad one day, but he just wasn't ready at this time or anytime soon. So bedtime came, we hugged one another, and the last words to each other were, I love you. And I went to wake him at 7:42 a.m. to find that he passed away. It took us 6 months, but we did get the cause of his death, and it was caused by an opioid overdose. It was heroin laced with fentanyl, and he was 19 years young. Luke was a loving, caring, loyal, and very funny young man. He loved deeply. He was always up for an adventure and always fought for the underdog. He was so emotionally connected with other people that he often felt other people's pain like it was his own. His life mattered, and our lives have never been the same. I miss him every waking moment. I wake up with pain and brokenness. I've come to realize that the pain will never go away. I am trying and learning to find joy through the pain. Luke did not plan to die. He wasn't an addict. His death was caused by an accidental overdose with a recreational drug that I said earlier was laced with fentanyl. He was planning his future when this happened, and his death has impacted so many people. Those who knew him, including his brother, will never be the same. And I remember Luke for who he was in his life. His overdose, how he died, does not define him. How each individual dies does not define each individual. And I think it's really, really important that we remember that, particularly in the pandemic with the tainted drug supply, that how they died doesn't define them. We have to get rid of the stigma that is attached with it. And we have to remember and acknowledge these people for who they were and who they are as we live with them in our hearts forever. And each and every life matters.
Thank you, Melissa, for sharing your story. I can't imagine, and I appreciate you coming on and sharing your story with us, so we all can learn from your story. It's always difficult hearing Melissa's story and then shifting over to getting into some more nuts and bolts of the discussion. But I think from here, I really want to bring us over to have some discussion with our health and social service providers to get a sense of what it is that's happening in the community, what services are being offered, what we're looking at addressing, our challenges, as well as our next steps in moving forward. So Dr. Rampton, I'm going to ask all the panel members if you can maybe join us. And I'm going to begin with Dr. Rampton.
Hi, everybody. You can hear me okay?
Great, thank you.
Yeah,
Yes,
okay.
I can hear you. So Dr. Rampton is an emergency medicine physician at the Royal Victoria Regional Health Centre and addiction medicine at the Canadian Addiction Treatment Centre, as well as Chronic Pain Centre. I could say so much more. Actually, Dr. Rampton's bio is incredible, and all the work that he has done locally, provincially. There's a lot of work that you certainly have done, but I'm going to just begin with asking you a very broad question. Dr. Rampton, if you could share with us a little bit about your role related to opioids and share with us what are some of your greatest challenges? So what is it that you're currently
well, my role with opiates, well, it's multiple, like through Emerge, and we're certainly dealing with the crisis going on. But I also, and I've worked in Emerge here for 20 years in Barrie, but I've worked in an addiction clinic for 17 years now, in a chronic pain clinic for about the same amount of time. So I have a pretty good reflection of everything that's going on. But probably the best thing is just sort of reflect through from the start, what we're seeing in emerge. I can tell you in the 20 years that I worked, us emerge docs, we would see maybe one overdose a year, maybe, collectively in our whole group in a day. So if I worked in a year, I would see maybe one. And starting, I can tell you when it started. It started in July of 2016, and that's when powdered fentanyl became available. And then I can tell you now, in RVH, we have 5 docs on at a time. We don't get through a single shift without each of us seeing at least one. So it's nonstop in Barrie, and people come in and either dead or they've had Narcan in all very different states, or they have infections from IV drug use. But it's become really the expectation in that hospital is that you're going to see that when that comes in now, and with everything that's coming on. In the addiction side of it, I think what people, as the person that's died, Luke, what people need to understand, it gets stereotyped that it's street people. So I can tell you in our addiction clinic, we have about just under 1,000 patients, and we run around 900 to 1,000 patients always. And I can tell you that maybe 5% or less that I would consider street people. These are homeless people, and they weren't street people to start with, but they are homeless now. But 95% of the people are probably majority people that have signed in here have someone that they know. So we've had doctors, we've had dentists, we've had counselors, we've had major business people, nurses, you name it, I've taken care of them. And it's multifactorial why people come into an addiction. And there was a time where OxyContin was a big deal and got a lot of people hooked. But there's always been some drug that's been the issue. And even in my addiction clinic, up until again July of 2016, so at that point I'd worked for 12 years, 0 overdoses on any patients in the program, who had an accident overdose. Since then, I personally, of my patients that I've followed, had 20 patients die, and not a single one of them were suicidal. So irrelevant, they had an addiction, they were in a treatment, they were stabilized. But there's some people we call harm reduction. So they're in a program, they're being treated, they're still doing drugs, but they're doing less. They have access to doctors, they have access to treatments and counseling. And I knew them all well, and I can tell you not a single one of them was suicidal. And it was all caused by, the powdered fentanyl process that's come along. And there's stronger stuff, right? There's carbafentanil. There's a new drug called, I think it's called phenyl 17 on the street now. It's even stronger than carbafentanil. It's basically, you take it, you're going to die. And it doesn't matter how much Narcan you have around. But that's what is on the street. Why is it there? It's not coming from the cartels. So it's the dealers, the last guys that are cutting it, because you can buy powdered fentanyl online, have it delivered to your house by Canada Post for about $200. And that takes your, whatever drugs you're selling, it takes $1,000 and makes it $10,000. And people say, well, they'll kill some people at times. I can tell you if someone dies, and it's like right now, there's purple heroin, there's blue heroin, there's orange heroin on the street. Someone overdoses on that drug, I will guarantee you that dealer is sold out by the end of that day. People, you'd think they would avoid it, but it's the understanding addiction and the high that people want to get. And now, the Narcan's around, that helps, but the people, they're playing Russian roulette with a loaded pistol. There's no bullet missing. It's just a matter of time. And then, the chronic pain I see, I see on the Q&A, there's a question from someone with chronic pain. The issue for chronic pain patients is that public perception, newspapers, even our own medical college, wanted to take the doctors out of the queue of being the problem. And so in chronic pain, 30% of the population have chronic pain. Only 3% of our patients are on opiate medication. So they get, unfortunately, they're labeled. And so if you don't have a doctor and you come into an emerge or a walk-in clinic, you're getting labeled. And it's unfortunate because it's impossible to sort that out when you meet the person for one time on that aspect. And, I work in a place where we offer either methadone, Suboxone. Harm reduction works. We have a 70% success rate. People get clean, they get back to their lives, they get their families back, they get working, and they start liking themselves again. The issues I see in there is, 80% of the people have a mood disorder. There are services available, but what's not available is one-on-one counseling. So most of these people have a childhood trauma, whether that's been mentally, sexually, or whatever, and they need some very strong one-on-one counseling that has training in addiction and mental health, and that is not group therapy, because what's available is group therapy. But if you in a public system and you don't have a private healthcare, that waiting list is 2 years, maybe, or longer for private, when you can't pay for it. And that person's probably not gonna be alive in 2 years if they don't get that help. And so basically with that, that's what we offer. That's available. That always is available in the community. We have the clinic. We've been our clinic's been in Barrie since 2001. We have a same day walk-in policy. That's 7 days a week. Where
Hey, you're addressing my next,
Yep.
thank you. I was wondering if you did
that
have,
didn't go. It was always there, but people. It's like everything with COVID. It's like an emergency department. When COVID broke out, our emergency department, you could have dropped a pin in there. No one. Everyone's afraid to come in. And the same thing. People are afraid to come into clinics. They're afraid to go anywhere where there's other people and they might catch something. So we saw our new patients drop in numbers when the crisis was going the wrong direction, right? And I think that's just fear of going to a community thing, right? And then we were in lockdown and people didn't want to go out and stuff. So
are
I
you
think
seeing
that
a shift in that, Dr. Rampton, in terms of, I understand early on people were not going to clinics. Is that an ongoing?
it's gotten better. And then, like, I know in our emergency part, when we had the outbreak at the hospital, it all happened again, where people did not want to come to the hospital. It doesn't happen so much at our clinic. We've had it set up where, really there's only one client in there at a time. It's pretty slick that way. So it's gotten better now, but there's still, but the issue too, like, there are a lot of people in the community that aren't addicts, that are drug users. And when I say that, we check all our urines on our patients. So I can tell you about 15% of the marijuana in our community is cut with fentanyl. So if you're buying marijuana off the street from your friend who you trust, and your friend's a dealer, 15% of that's going to be cut with fentanyl. And if your kid's smoking that, they have no tolerance, so there's high risk of overdosing. There is no heroin in town. It is not heroin. Like, I don't even think the cartels ship heroin anymore. It's all fentanyl, 100%. Cocaine right now in the community, what we see in our clinic is 60 to 70% of the cocaine is cut with fentanyl. And it all depends. So the problem now is, and we see it in our emerge, is not so much now with the lockdown, but before that, people go to the bars and they may have a so-called bump of cocaine, and it's fentanyl, and someone passes out in a bar, or they're at home and people, there are people just do cocaine once in a blue moon. They're social, like some of us might drink a beer, some of us might have a cigarette, I guess, but some people do cocaine and they're not addicts. But the problem right now is any recreational drug use is very dangerous, and that's what we're seeing, right? So when someone overdoses, they may get stereotyped, well, they must have been an addict. It's a way, I guess, of making people feel better about it, that someone died. But the issue is it could be any of us. It could be one of our kids. I have teenage kids, and I've had talks with them and told them never to, but the kids are kids. And
I
the
think
same
you
thing
raised
with
an excellent point, Dr.
Yeah.
Rampton, that it can be, you've touched upon a number of issues here about it essentially can be anyone. We can all find ourselves in this situation, and that we've all have been touched by it. A number of people I would challenge that I suspect everyone who's participating hasn't been touched by it in some way.
Yep.
Now, there's a piece I would like to pick up on, and I'll probably go over to Kim Bray from CMHA, just around the piece in relation to counseling. I know the Canadian Mental Health Association is involved in the counseling of and addictions piece, mental health and addiction. So maybe, Kim, let's bring on Kim. And certainly the other panel members, if you want to join on in, I will ask a few follow-up questions as well. Thank you so much, Dr. Rampton. I might bounce back to you around some other additional questions, but I did want to follow up around that piece too with Kim Bray from CMHA. Kim, are you on the?
I'm here.
Oh, there you are. Sorry, I couldn't see you. So Kim, I'm going to follow up with a similar question to you. If you can tell me a little bit about the work that you're involved with at CMHA and the work that they're doing around opioid use and addictions. I mean, it's hard to tease it out and separate it specific to opioids, but if you could respond to that around the services that are available and what's offered.
Sure. We continue to be to offer the same services we have for a long time. So we do offer the outpatient counseling, which is done either by individual or group. So both options are offered. We continue to make referrals to residential treatment when that's something that's going to be helpful or something that has been requested. We do referrals to local agencies, such as Dr. Rampton, for instance, for medication-assisted treatments. So we're continually doing all of those things, and we're doing them virtually now rather than in person. But we also do a number of other things, such as education, right? Education, not only to our clients about overdose risks and medication interactions and just some harm reduction and safety planning. But we also do education to the community about, what substance use is all about, some of the different layers in what is a very complex scenario. Again, talking a lot about safety. We're active in the community with the SMOS committee, so the Simcoe Muskoka Opioid Strategy. As an agency, we're heavily involved, and many of us are personally involved in the different pillars for that, which also includes the pursuing of the supervised consumption site that we're actively engaging with. We've identified that very clearly there's a piece of the continuum of addiction services that's just not being met. And so we've been working for the last couple of years toward making that a new addition to the continuum. It's not the answer, but it's an addition to the options that will be available.
Thank you for that, Kim. Kim, I just want to follow up too with regards to the counseling component of the services that you offer. Is there a waiting list? I often hear people speak about waiting lists, and I have questions that come in around, is there a waiting list, or how do people access your service?
Sure. If we're speaking just of Barrie, accessing our service is mostly done through our on-duty phone line at the moment. And that will connect a person with one of our on-duty workers. They can talk about what it is they're looking for, and they'll get them set up for an intake, and it will go from there. We do occasionally have waiting lists. One of the, it's an unfortunate thing, but a fortunate thing for others, is that over COVID, we actually have had very few waiting lists. If they've happened, it's only been for maybe a day or a couple of days or a week at a time. Sadly, that means that more folks are out there continuing to use as opposed to looking at making some changes. But for those who are looking for the help right away, we've been able to offer that. We do have a partnership with the RAM clinic as well. So we do priority referrals that come directly from the RAM clinic for individuals using opioids or alcohol.
And can you tell people what the RAM clinic stands for?
Sure, it's rapid access addiction medicine. So I don't work for them, so I can't, go into detail, but it generally
self-refer or?
Yeah, it could be referred by somebody else, but most things are self-referral when it comes to addiction services. The idea behind the RAM clinics is that, it's quick, it's rapid. Get in, get seen by somebody. There's a lot of medication-assisted therapy that happens through there. And they have a nurse practitioner, they have counselors for brief counseling. And it's kind of a place to go to get the first steps underway. And then they generally will refer out to other community partners, as well as like other longer term treatment options.
Okay, thank you, Kim.
Sure.
Depending on time, I want to make sure that I have an opportunity to have all our panel members involved. So Mia, I'm going to move to you next, just in terms of Kim had raised the term, as had, others raised the term of harm reduction. I wonder if you can, just share what harm reduction really encompasses. Tell us a little bit about that and your work around harm reduction.
Sure. So harm reduction is really a pragmatic approach to addressing the opioid crisis or drug use in general, and meeting people where they're at with their use. So really the programs and policies and systems are in place to reduce the harms that come from a social and health perspective when people are using substances. So, there's a number of harm reduction activities that we are conducting across our region, and certainly in Barrie. Some of them are short term, and some of them are, looking at long-term advocacy roles. So as far as short term, making sure that everyone in the community has access to naloxone. So we work very closely with our community partners to continue the free and widened access of naloxone through distribution in the community, through our partners, to our local police and fire to ensure that they have naloxone available for their community response. And even the city of Barrie at this point is committed to making naloxone available in their municipal buildings for public access. So naloxone is one piece of the short-term strategies to address the opioid crisis. Another activity is really, promoting harm reduction messaging through our partnerships. And encouraging the buddy system at this time, because we know that, with many of the public health measures for COVID, people may be using alone or decreasing or have decreased access to typical services that they would have. And so we are promoting, as you had mentioned earlier in your presentation, 2 different call lines that are available in the province for people that are using substances alone and at risk of an overdose. And so that's a call line through Grenfell Ministries in the city of Hamilton. They do support the whole province with this call line. And then as well as the Craftsman Center in South Simcoe of our region has a line that's operating. I think the Craftsman Center's line is open 10 at night till 3 a.m. in the morning daily. And the Grenfell Ministries call line is actually 24 hours a day, 7 days a week. So with that, sorry, go ahead, Claude.
Those are 2 separate lines, and anybody
Yes.
From our area can phone into either one of those lines.
Yes, they'll speak to somebody who has lived experience. So there's someone who's, going to provide them with non-judgmental support. They negotiate a plan for how that person will respond to the person who's using the substance. So if they'll get details of where they're located so that 911 can be called if that person that is using the substance goes unconscious. So the person, it's essentially like a virtual supervised consumption service that they're providing, or they call it virtual overdose prevention services. Drug checking is another way of addressing the crisis right now. There's different options out there. There's the inexpensive testing strips that test for the presence of fentanyl. It helps people make a decision from a harm reduction perspective of whether they want to reduce the amount they use or use it at all. right up to the large mass spectrometers that are available in facilities like St. Michael's Hospital and CAMH in Toronto, where they really do like the analysis that tells us community partners exactly what substances are in the drugs. And we know that, many of the drugs at the street level are contaminated with many toxic components that are causing the problems that we're seeing right now. From a long-term approach, really, the advocacy that we're doing, as Kim mentioned, with the supervised consumption site in Barrie, we are a co-applicant with the CMHA Simcoe County branch. They're the lead for the application. There's a substantial amount of literature to support harm reduction measures that include the establishment of supervised consumption sites in communities that have high rates of emergency department visits and deaths related to opioids. And we know that we have that here in Barrie. You've looked at our stats. Wraparound services and referrals are part of that health-based service model of delivery. And so, all of those services that need to be accessed by people who are vulnerable and using substances and are at risk of overdose would have that opportunity to have the services and referrals right there available to them in a health facility. Safe supply is another piece that's really, being piloted across the province and across the country through programs that have been supported financially from the federal government. And so really it's just to address the toxic supply that we're experiencing in our communities right now. And it's by providing prescription grade alternatives like diacetylmorphine and hydromorphone for people that are using. So it's a little bit different than the methadone and Suboxone treatment model, but it is a way of providing a safe, uncontaminated supply to somebody who's using. And decriminalization, is something that's been discussed for many years now. Really, when we talk about decriminalization, it's really related to the personal possession of psychoactive substances to address the social determinants of health perspective by reducing those harms that are associated with the involvement in the criminal justice system. So, there's so many things that we could be doing advocacy-wise. Certainly, those are the long-term approaches, but for short-term are definitely, promoting access to naloxone, encouraging people not to use alone, and if they do, using those services that can respond with 911 if they do go unconscious.
Thank you, Mia. That was a very comprehensive answer. So you've given us a lot to think about there. I think what I'll do now, in the interest of time, I'm going to move over to Sergeant Detective Brouillard. I wanted, Detective Brouillard, could you tell us a little bit about your role with Barrie Police Services and the work you do and what you are seeing out in the community?
I'm the Detective Sergeant in charge of the investigative services in regards to opioid. The departments that are affected with that would be, I'm in charge of the intelligence section, in which we try and identify who the dealers are. The detective's office, who would be the investigators that go to overdoses, and the drug unit and surveillance. The doctor touched on a lot of the points that I would touch on as far as the availability of fentanyl and opioids on the street are probably one of the biggest problems that we have in the fight. As he alluded to, cartels used to move cocaine from South America and heroin from overseas. That's no longer a requirement. So that used to be more difficult, but now with the advent of the internet and mail services, small amounts can be shipped to people's homes. But even at a larger scale, a lot of these precursors aren't illegal to ship for testing purposes and so on and so forth. So containers of precursors can be shipped overseas and then they're mixed together here. And again, we're depending on people who are mixing these, who aren't trained and don't have the education. So the actual end user doesn't know what they're getting and how many times it's been adulterated along the way down the chain. He is correct that we have seen, at least to my knowledge, 2 samples that were sent for testing that tested back to fentanyl UF17 in Barrie, which we understand is more toxic than a lot of what we've seen. I don't know the toxicity compared to carfentanil, but This was fairly recently that we've seen 2 samples. And again, like you touched on about people not being afraid of some of the stronger versions of the drug. Recently, we've gotten information from street level users about a substance that they're referring to as the gray death, which is a fentanyl, but it's gray in color, it looks more like concrete, and it is making its way, but we've also seen other substances that are blue and purple that are also being called gray death, and that's being called that because it's hyper potent. And again, it's to most people who aren't users, that would be a good reason to stay away from it, but it's almost being used as a marketing ploy, as it's the next level potent. So that's concerning.
Sergeant Brouillard, as you speak of the different types of drugs you're seeing, I do have a question here around, someone has asked if you could explain the difference between purple fentanyl versus orange versus regular fentanyl.
There technically is no difference. It could be, I mean, purple fentanyl today can be blue fentanyl tomorrow, and orange. I haven't seen orange. I've seen red, purple, blue, the gray. Essentially, it's a marketing ploy that, to my knowledge, it started around Hamilton in Ontario, but it's made its way here quite some time ago. But it's a marker for people, for dealers to identify their drugs and create a bit of a demand. So if somebody's, originally it's purple, but if you had the purple heroin or fentanyl, it was believed to be of a better quality, so people would look for that, and essentially it's a marketing ploy by drug dealers.
And why would drug dealers, what would be their motivation to even cut their drugs with fentanyl? What's the purpose of using fentanyl? If it's killing people who use it, what would be the primary purpose of the motivation for using it?
People have been using, well, they're trying to mimic heroin. Heroin's been in use for hundreds of years, and it's, I don't think, like for the most part, the mixing of fentanyl over cocaine, I personally don't understand, because it kind of is counterintuitive with a stimulant being mixed with a depressant. But otherwise, substances that are being put out as opioid, fentanyl, to the dealer, however they can, whatever they have access to at that time that they can sell for a profit is what their motivation is. So
fentanyl would essentially be less expensive to make and produce than, say, something like cocaine or heroin. Well, the first two, the cocaine and heroin, are produced, so you'd have to go through the channels of having connections. It demands a more entrenched level of organized crime to bring, let's say, cocaine from Colombia or heroin from overseas, versus, I mean, somebody with a bit of wherewithal could, using the internet, bring in fentanyl with fairly low risks. You're not having to take it from South America through the US into Canada. You can just rely on a postal system to bring it to you. Interesting. Thank you for that. I have another question here from a participant. How can we help as individuals? I am Indigenous and wondering if there are supports for people and their families. I'd have to pass that question along to. Oh, and sorry, that's directed to the general panel group. I'm not sure who would want to take that. Maybe Kim, would that be something?
I can definitely speak a little bit to it. We are one of the community agencies that does provide support to, we sort of group them as significant others. So that might be family members or close friends who are impacted by another person's use. So we offer that individual therapy too. And it's not about, helping somebody figure out how to fix their loved one and how to get them to stop, but it tends to be more focused on how do you take care of yourself while you're coping with a situation where your loved one is perhaps having a difficult time.
Okay, thank you for that, Kim. I have had a number of questions come in, Detective Sergeant Brouillard, in relation to what you might be seeing with cannabis or marijuana laced with fentanyl. I wondered if you could speak a little bit to that.
In honesty, I'm not doubting at all what the doctor said. He's got boots on the ground, but I haven't experienced that or heard of that. It's always a fear. As a dad, that's always been one of my fears and one of my biggest fears, because like he said, teenagers will be teenagers, and that seems like it's much more widely accepted. So it is concerning to me. To some extent, it would make sense if, again, about profit, if somebody, with some ill intent wanted to get people hooked on whatever they're selling, it would make sense. But personally, I'm not aware of a case like that.
Okay. Dr. Rampton, I think you were identifying that through some testing, you were finding that, and I don't recall exactly the stats, but about 50% of cannabis and berry is laced with fentanyl. Sorry, I have a question
Yeah.
regarding that.
No,
Around
that was just, it's 15%.
15.
Yeah,
Okay.
and that's in patients that are being tested in our addiction clinic. So, overall in the whole community, that probably number is lower because the people that are buying marijuana in our clinic, they're buying the drug somewhere, right? So they're getting their marijuana from a dealer. So I would assume that that rate is higher in my population. But in the overall community, I bet you it's 5% at least for that. And to answer the one question you had about why do they lace cocaine and why do they lace marijuana? The simple answer to that is if I'm selling marijuana and you're selling marijuana and I have fentanyl in mine, my patients become addicted without knowing it. They just put enough in. So every time you smoke it, you're getting a bit of opiates. And then when you don't smoke it, and I go buy my marijuana from you, I don't feel so good because they don't recognize that they're in withdrawal. And so it's a way of a dealer making sure that they're getting their repeat customers. And it's the same thing with the cocaine. But the problem with the cocaine is that it's like everything. They put too much in it, right? With marijuana, they dust. We call it dusting. So they'll put it in a bag and shake so you can only get so much in it. But powdered fentanyl looks like powdered cocaine. So they can put too much in it, and that's what happens.
Okay, interesting. Another question I have that has come in from our participants is how long is a wait list for residential treatment? Is there anyone on the panel that's able to answer that one?
I can. It varies. Before pre-COVID, some places we would sort of generally expect the average length of time to be maybe 6 weeks of wait. Of course, some places could get in much faster, and if you have benefits or the finances to go private, that's often immediate. But if waiting for an OHIP-funded bed at a treatment center, let's say a 21-day treatment center, which is sort of the starting point, it's now looking at several months. Because of the shutdown with COVID and not being able to provide those services for a while, there's sort of been a backlog of people now waiting to get into treatment. When we look at the longer term residential treatment, 6 months to a year, obviously they don't take people as frequently because they're a longer stay. So that always leaves a bit more of a waiting list to get into.
Okay, thank you, Kim. This might be another question for you as well, Kim. I know that you have been heavily involved in work in relation to anti-stigma and anti-stigma campaigns. I know it's very difficult to answer this in a quick statement, and I'm recognizing we're actually a little over time. So I appreciate panel members and the participants staying on for a couple minutes longer. So I think I may wrap up with this last question in relation to stigma, but this came in through one of our participants. How can we address the stigma within healthcare facilities to make services more welcoming and accessible to people struggling with addiction?
If only that were an easy answer. Unfortunately, it's one of those processes that is long and sometimes painstaking. It involves each individual person to really do some good self-reflection on their own beliefs and biases. And then it needs to grow beyond that to the systems and practices within each organization, and then bigger into the more global system of healthcare.
Thank you for that, Kim. I know there are so many questions, and I'm being I find it challenging wrapping up. So I'm failing here as a moderator in terms of I'm finding all of you incredibly interesting. I'm learning so much from you, and I'm sure the participants are as well. So we do have a number of questions that continue to flow in, and I wish we could stay here longer, but I do recognize that many of you have also identified some other commitments that you need to get back to. So I will be respectful of that. And I do genuinely thank you all. I thank the City of Barrie for their partnership in providing this webinar and this virtual event for us. And I really sincerely thank you all as panel members in participating, lending your knowledge, experience, and expertise. But I would like to have Melissa just close us off with sharing. Melissa, from your perspective, and I know you also work with the moms group, which we can share. You know, I know you have shared a lot of information around that in the past, but I would like to provide an opportunity for you to open and close our event with just sharing, if there were one thing from your perspective that you would like to share with individuals, families, the community, what would that be?
Oh, there's so many things. First, I think it's really important for families, parents, to educate themselves and their children, not to do it individually, but to do it as a family, to foster relationships that allow your children to have open communication with you. So when you have that moment where they're telling you something and you're just going to go through the roof because you're so scared and you don't know how to answer, keep calm, keep that line of communication open so that they know that no matter what, they can come to you and with their problems, if they've tried or they've used or they have an addiction, that they know that you're behind them and that you love them. And it's fostering a relationship with individuals that is based on truth, honesty, and grace. We have to have grace along with truth and honesty. We can speak truth all we want, and without grace, we're not going to get anywhere. And somewhere along the lines, we've lost grace in our community. And I think it's being able to talk about it with your families, with your loved ones, with others, to reduce the stigma that is associated with addictions and using drugs. And we can only do that if each of us takes that on and decides that we're going to participate in this. And it starts with me, and it starts with you, and it starts with the whole community. And we have to work together. We have to work with the doctors, the nurses, with police, with Mental Health Association, with the health unit. We are all in this together. And we just have to support one another.
Thank you for that, Melissa. Very, very well stated. So I thank everyone for their participation. And again, that is a beautiful closing statement. We are all in this together. I know there have been a number of questions that have come in, and my sincere apologies that we can't get through all the questions. I even tried to push it a little bit longer for our Q&A section. There's just so much to address. I hope we keep the dialogue going further, we open up these discussions, and we continue to work collaboratively as a community. And what we as a group are going to be looking at doing is following up with some of the Q&As that didn't get answered and flowing that through to the participants. So we will group those questions, we'll look at answering them as best we can and forward that on to everyone, and as well as with the PowerPoint presentation and links to resources, etc. So again, thank you, everyone. And yes, we are all in this together. Thanks again. Bye, everyone.